Hi all, welcome back once again. In the current video, we are going to discuss about approach to a patient with abdominal pain in the emergency department. I am Dr. Prakash Babu, Associate Professor, Department of Emergency Medicine, KIMS and RC, Changalpattu. Abdominal pain is one of the leading principal reason for visit to an emergency room. It accounts for 10% of all cases presenting to the emergency department. In 40% of patients, the diagnosis is not clear during their emergency stay, but in the 60% of patients, there will be a potentially serious diagnosis. A good history coupled with a proper systemic examination helps in establishing the cause, and further investigations will support your diagnosis. In the current video, we are going to learn about the principles of diagnosis and the principles of management of abdominal pain. We are not going to touch any specific cause. So you all know the abdomen is divided into 4 quadrants by 2 lines, one running vertically through the midline, the other through the umbilicus. So there are different organs located in different regions, and it is depends on which region the organ is present intra-abdominally, the pain is present for the patient. So let's have a look at what organs are situated in which quadrant of the abdomen. Right upper quadrant, majority is occupied by liver. Under the liver, you can have right kidney, the colon, pancreas. The small portion of the tail of the pancreas is located in the right upper quadrant, gallbladder, and part of the small intestine. The left upper quadrant, again, small portion is occupied with the liver. Majority is by spleen under the costal margin, left kidney, stomach, colon, pancreas. Majority of the portion is occupied with the pancreas, and loops of small bowel are present. Right lower quadrant, mainly the colon, parts of small intestine, along with ileocecal junction and the appendix, the right ureter, right ovary in females, right fallopian tube in females. Left lower quadrant contains colon, small intestines, left ureter, left ovary in females, and the left fallopian tube in the females. The midline, there is bladder, uterus in the females, and prostate in the males. Along with these 4 quadrants of the abdomen, the genitalial region, external genital region, is also considered a part of the abdomen. When we go into divisions of the abdomen, we'll see in detail. Similarly, abdomen has been divided into divisions again by 2 vertical lines which pass through the mid-clavicular line, the right mid-clavicular line and the left mid-clavicular line, and 2 horizontal lines. The first line up at the upper line passing to the transpyloric plane. It passes through the pylorus, and the lower line which passes through the transiliac crest. So it divides the abdomen into 9 quadrants, and as I told earlier, genitalia is considered one of the quadrants of the abdomen, which makes a total of 10 divisions in the abdomen. The divisions are named as the right hypochondriac, epigastric region, left hypochondrium, right lumbar, left lumbar, umbilical region, right iliac and left iliac regions, and the hypogastric region. There are different structures in all regions. If patient is complaining of abdominal pain in a particular region or particular division of the abdomen, it corresponds to one of the organs located intra-abdominally in that particular division of the abdomen. So let's look at what organs are situated in which division of the abdomen. Right hypochondrium contains majority the liver. Under the liver there is gallbladder, right kidney, and the small intestine. Epigastric region, major portion is occupied by the stomach. A part of liver comes right lobe of the liver comes into the epigastric region. Body of the pancreas, part of duodenum, spleen, and the adrenal glands are located in the epigastric region. Left hypochondrium contains the spleen, colon, left kidney, in the pancreas. Right lumbar region mainly contains the gallbladder, parts of liver, and the right colon. Umbilical region or the central region contains the umbilicus, parts of the small intestine and duodenum. Left lumbar region contains descending colon and the left kidney. The right iliac region contains mainly the cecum and the appendix. Hypogastric region or the pelvic region contains urinary bladder, sigmoid colon, female reproductive organs like ovaries and the bladder. Left iliac region contains the descending colon and the sigmoid colon. So now we know divisions. What are the causes of abdominal pain? In each of those divisions, let us have a brief look. So the right hypochondrium mainly, the liver occupies the major portion of the right hypochondrium and the gallbladder. So gallstones, part of the stomach comes into the right hypochondrium. So gastric ulcer, pancreatitis, inflammation in the tail of the pancreatitis, hepatitis and liver abscess are the major causes. The epigastric region, gallstones, gastric ulcer, pancreatitis, GERD and mainly gastritis, epigastric hernia and biliary colic can be present in the epigastric region. Left hypochondrium, gastric ulcer, pancreatitis, duodenal ulcer, biliary colic, splenic abscess. Right lumbar, renal stones, especially from the right kidney, pyelonephritis, constipation and lumbar hernia. Left hypochondriac, left kidney is located, left adrenals are located, renal stones, diverticular disease, again infections of the kidney, constipation, inflammatory bowel disease, and colonic disorders cause pain in the left lumbar region. The central or the umbilical region, gastric ulcer, pancreatitis, and as you know, appendicitis, early appendicitis. Appendicitis is a migrating type of pain which starts around the umbilicus and then spreads into the right iliac region to localize into the right iliac region. Inflammatory bowel disease, small bowel obstruction, and umbilical hernia can cause pain. The right iliac region, appendix and the cecum are located. Any disease of appendicitis, cecoileitis, constipation, and cecal disorders, groin pain can cause pain in the right iliac region. The pelvic region or the hypogastric region, urinary tract infections, appendicitis, diverticular disease, inflammatory bowel disease, and pelvic pain arising from uterus or the ovary. Mainly, you need to look for ovarian torsion. Diverticular disease, sigmoid volvulus, inguinal hernia are the common causes in the left iliac region. So, apart from localized pain, abdominal pain most often can be diffuse, especially in more severe diseases like peritonitis, pancreatitis leading to peritonitis, sickle cell crisis wherein there is blockade of the vessels in the abdomen and that leads to mesenteric ischemia which leads to diffuse abdominal pain. Early appendicitis, there can be a diffuse type of pain. Patient may not be able to localize to the umbilical region. Mesenteric thrombosis, gastroenteritis, dissecting a ruptured aneurysm of the aorta, intestinal obstruction, diabetes mellitus, inflammatory bowel disease, and irritable bowel syndrome cause diffuse abdominal pain. Apart from the abdomen, there are certain other causes, extra abdominal causes of abdominal pain, which mimic abdominal pain, but not the cause is not located within the abdomen. It can be from the thoracic, like acute coronary syndrome. You know that in inferior wall MI, you can have epigastric pain. Pneumonia, patient can have the right or left hypochondriac pain in pneumonia. Pulmonary embolism, the lower lobes are involved. Again, you can have right hypochondriac pain. Herniated thoracic disc can present as abdominal pain due to radiation. Pericarditis and myocarditis, especially involving the lower border of the heart, can mimic abdominal pain. Genitourinary system, mainly the testicular torsion, because the testis has distended from the abdomen. Testicular torsion can present as pain in the inside the abdomen. Sometimes there can be a torsion of an undescended testis which causes abdominal pain. Abdominal wall, muscle spasm, muscle hematomas, and herpes zoster are the common causes. Infectious causes like streptococcal pharyngitis, especially in children, it can present as abdominal pain. Rocky Mountain spotted fever, where there is again a mesenteric ischemia like picture. and mononucleosis can cause abdominal pain. Systemic disorders are endocrine disorders like diabetic and alcoholic ketoacidosis, uremia, porphyria, systemic lupus erythematosus, vasculitis, glaucoma, hyperthyroidism. Anything can have abdominal pain. Toxic causes of abdominal pain include methanol poisoning, heavy metal toxicity, scorpion bite, snake bite, and black widow spider. Heavy metal poisoning, especially of arsenic and mercury, will mimic acute gastroenteritis-like picture. So coming to the pathophysiology, how abdominal pain is caused. The local structures, the structures of GIT and genitourinary systems are located within the abdomen. It can be from intra-abdominal or extra-abdominal structures as we discussed earlier. There are three main pathways which conduct pain. One is visceral, the second is somatic, and the third is referred pain. So coming to the visceral pain, it results from stimulation of autonomic nerves invested in the visceral peritoneum surrounding the internal organs. The stimuli for this type of pain include distension of hollow viscus by fluid or gas and capsular stretching of solid organs from edema, blood, cysts or abscess are the most common stimuli. It is specifically poorly characterized and patient will not be able to localize to a particular point. This is a specific feature of visceral pain. Usually described as intermittent, crampy and colicky because hollow viscus there is muscular activity, so colicky pain occurs. Visceral pain usually correlates with the embryonic visceral segments. The foregut structures like stomach, duodenum, liver, and pancreas are associated with abdominal pain, upper abdominal pain. Midgut derivatives like small bowel, proximal colon, and appendix are associated with periumbilical pain. Hindgut structures that are distal colon and the genitourinary tract are associated with lower abdominal pain. Somatic pain, it is caused due to irritation of the parietal peritoneum, not exactly the disease of the viscus involved, caused by infection, chemical irritation, or the inflammatory process. It is described as intense and constant pain, and patient will be able to localize visceral pain, somatic pain better than the visceral pain. Referred pain, it is a pain felt at a distance from its actual source. It occurs due to peripheral apparent nerves from many internal organs enter the spinal cord through nerve roots that also carry nociceptive fibers from other locations. Examples for referred pain include epigastric pain in the inferior wall mi and shoulder pain in hemoperiton. Certain patients are at higher risk of developing serious underlying disorders, and certain patients are at lower risk. The patients who are at higher risk for having a serious disorder when they are presenting with abdominal pain include age older than 60 years. The pain will be inappropriate to the clinical presentation. Patient will have more serious disorder and less severe pain because of neural degeneration. Previous abdominal surgery, including obesity or surgery, history of any inflammatory bowel disease, recent instrumentation like colonoscopy with biopsy, known abdominal, pelvic, and retroperitoneal malignancy, active chemotherapy, patients on active chemotherapy, immunocompromised patients, including those on low dose prednisolone. If the patient is presenting with fever, chills, and systemic symptoms like vomitings, they will have a more serious disorder. Women of childbearing age can have an ectopic pregnancy, which is a dramatic event. And recent immigrants, language or cognitive barrier can impair the actual communication of pain to the doctor between doctor and patient. So they are considered as higher risk patients. So as soon as you see a patient with abdominal pain, you need to rapidly assess and stabilize the patient, triage appropriately, and measure all vital signs at first contact. Start registration as per the triage protocol. Based on which category you have triaged the patient to, you need to start your registration efforts. Order fluids and blood replacement as required by the patient. A bedside USG is the first and foremost screening test that has to be done. It can detect free fluid, distended bowel loops, and can also assess volume status by using the RUSH protocol. So once you have stabilized the patient, You need to go into complete history taking, evaluate pain using standard approach like Socrates. You can use any other mnemonic to remember, but Socrates is a preferred mnemonic. S stands for site of pain. Ask the patient where the pain is, what body parts are involved, onset, when did the pain start, and also ask whether the pain is sudden, rapid, or more gradual one. Ask about the character of the patient. Let the patient describe the pain, whether it is sharp, dull, sore, or stabbing. As you know already, if it is a somatic pain, it will be sharp and properly localized. If it is a visceral pain, it will be dull and poorly localized. Hence, you can differentiate between somatic and visceral pain. When the patient is having visceral pain, he is in fact having a more serious disorder, and you need to be very aggressive in our management. Radiation. Does the pain spread into other parts of the body or other areas of the body, or does it stay at the site where the pain is there? Associated symptoms. It may happen that the patient experiences other symptoms as nausea, vomiting along with pain. We have to take a complete list of associated symptoms like fever, vomiting, diarrhea, body pains, chills, those things. Timing is very, very important. Timing is different from onset of pain. Ask the patient when did he or she feel the pain the most. Is it constant? Does it happen at specific time of the day? Whether a certain movement is aggravating the pain. You need to specifically ask about exacerbating and relieving factors. Ask the patient specifically what is making the pain better or what is making the pain worse. Also ask about severity. Explain the patient about the numerical analog scale, which scores pain from 0 to 10. It's a subjective measurement. It's not an objective measurement. Ask the patient, 0 is no pain and 10 is the worst possible pain. Let the patient score the pain. The patient gives whatever number from 0 to 10, you need to enter that in the case sheet. Or you can use facial grimace scale, which is an objective, and it grades pain into mild, moderate, and severe types of pains. Vomiting, record anorexia, nausea, and vomiting. Ask about duration, onset, and number of episodes of vomiting. Record in chronological order of pain and vomiting. Vomiting following pain implies usually a surgical cause. Specifically, ask about bowel habits and document it properly. Inquire about frequency, quantity, and quality of bowel movement. Passing flatus, any recent change in bowel habit, abdominal distension. There are certain specific questions which yield more information than the regular questions, especially ask the patient about his age, how old are you? Advanced age means increase the risk of disease. As we know, more than 60 years, they will have more serious disorder than patients less than 60 years. Whether the pain came first or the vomiting came first, if the patient is having both pain and vomiting, pain first is always worse. How long have you had the pain? Pain for less than 48 hours is usually worse. Have you ever had an abdominal surgery? Consider obstruction in patients who report previous abdominal surgery and present with abdominal pain and abdominal distension. Is the pain constant or intermittent? Constant pain is usually worse. Have you ever had this type of pain before? A report of no prior episodes is worse. Do you have a history of cancer, diverticulosis, pancreatitis, kidney failure, gallstones, and inflammatory bowel disease? Do you have HIV infection? How much alcohol do you drink per day? Patient may not be able to answer directly for these questions. Ask them specifically about any previous medical records. Review all the previous medical records carefully for finding out whether the patient had any similar episodes in the past. Ask the patient about pregnancy status, LMP, last menstrual period, test for pregnancy. If pregnancy test is positive, consider ectopic pregnancy. Ask where the patient is taking any antibiotics or steroids. Effects of the drugs may mask any infection. They may reduce or increase the signs present. The pain starts centrally and migrate to the right lower quadrant, high specificity for appendicitis. Where the patient has any history of vascular or heart disease, hypertension, or atrial fibrillation, you need to consider mesenteric ischemia and abdominal aneurysm. The patient has one of the cardiovascular diseases earlier. Following your history taking and careful documentation of the history in patient's own words, you need to proceed for examination. The patient should be placed comfortably, preferably in supine position. Examine for signs of trauma, bruise, and skin lesions. Ask the patient to localize the site of maximal pain with one finger. Look for sinuses, tracts, and swellings over the abdomen. Look at the shape of the abdomen, whether it is distended, flat, or scaphoid. Usually, a scaphoid or a flat abdomen should be normal. A distended abdomen is of concern. Examine the hernial sites. Usually, intestinal obstruction is most common in patients with a hernia, obstructed hernia. Then auscultate for bowel sounds before going for palpation or percussion. If you go and palpate, percuss, and then auscultate, you are going to induce the bowels, and your bowel sounds will be either exaggerated or absent because you are stimulating the bowels. Carefully listen for bowel sounds and document how many bowel sounds you are able to hear per minute and look for any vascular bruit. Percuss for liver border, extent of the stomach, abnormal dullness or resonance. Specifically check for obliteration of the liver dullness. Now is the time for palpation. Palpation for any local rise of temperature, any tenderness, rebound tenderness, or godding. Look for hepatosplenomegaly. Palpable or pulsatile masses. If a mass is felt, define the mass in terms of location, extent, margin, and edges. No abdominal examination is complete without performing a perrectal examination and also a pervaginal examination in a female, which completes the abdominal examination. Note that rectal tone, contents of the rectum, feel for the prostate in males, presence of blood or mucus on the finger when you withdraw the finger is of utmost importance in diagnosing lower gastrointestinal bleeding. Imaging. USG is the initial screening modality of choice in patients with abdominal pain. A more accurate and precise diagnosis can be made using CECT of the abdomen. You can know what complications are there, how exactly each structure is delineated by doing a contrast enhancer CT of the abdomen. Pelvic organs can be better assessed using a CT scan rather than an ultrasound. Modality of choice depends on clinical features and the acuity of presentation. A chest X-ray or rectal X-ray abdomen might be needed in a patient whom you think there is a perforation to look for gas under the diaphragm. So let us look at what are the uses of abdominal ultrasound in a patient with abdominal pain. There are some critical diagnosis and some emergent diagnosis. Critical diagnosis, especially pelvis, USG helps in identification of ectopic pregnancy and the presence or absence of any intrapelvic hemorrhage. You can measure the aorta, cross-sectional diameter of the abdominal aorta to determine the presence of an abdominal aortic aneurysm. You can do a fast scan for detection of free fluid and intraperitoneal fluid indicating hemorrhage, pus, or extrusion of the gastric contents. For emergency purposes, in the pelvic examination, you can identify any intrauterine pregnancy or any ovarian torsion. A biliary or the right upper quadrant, you can locate gallstones, dilated common bile duct, which may be a clue to the presence of cholelithiasis. You can look for pericholecystic fluid or gallbladder wall thickening, which may be indicative of cholecystitis. Renal, you can locate hydrohydronephrosis, indicating possible obstructive uropathy, or you can locate pyelonephritis. Fast scanning, pre-intracranial fluid indicating ascites or hemorrhage. Cardiac, inferior vena cava distension, collapse as an indicator of volume status by using the Rush protocol. So there are some ancillary lab investigations which may not directly aid you in diagnosis, but they support your diagnosis. Urine ketones in suspected DKA, serum amylase, lipase, and LFTs in case of upper abdominal pain to look for any hepatitis or pancreatitis. Complete blood counts, electrolytes, coagulation screen, and class matching in patients who present with a shock. Urinalysis is an important investigation which gives a clue to the UTI. ECG is especially in patients with epigastric pain is very helpful to detect the cause of abdominal pain. So diagnostic algorithm for abdominal pain, this is an extract from Rosen's textbook of emergency medicine. You look for signs of shock to start with. If there are signs of shock, you start resuscitation by securing two large bore IV cannulas, administer fluids, crystallites 20 ml per kg. Within the first hour, you can repeat thrice. Rapid ultrasound to check for hemorrhagic confusion, hemorrhagic state. Consider surgical consultation as early as possible. There are no signs of shock. The history is suggestive of acute abdomen. Yes, consider surgical consultation or expedited imaging. There are no signs suggestive of an acute abdomen. You look for pregnancy or high suspicion for pregnancy. This could be due to an ectopic pregnancy, immediate ultrasound, and identify ectopic pregnancy or spontaneous abortion if present. No chance of pregnancy, then you proceed to look for peritoneal signs on examination. If peritoneal signs are present, consider upright chest X-ray films to look for any free air under the diaphragm for early identification. And you can go for a contrast enhancer CT to look for any complications due to peritonitis or the actual organ which is inflamed to detect the cause and plan your management. Peritoneal signs are absent. Look for location of maximal tenderness. If it is in the upper abdomen, check for Murphy's sign, check liver function test, lipase for pancreatitis, consider ultrasound for biliary pathology. Otherwise, CT with contrast for evaluation of gastric, duodenal, hepatic, and pancreatic lesions. The pain is diffuse. Consider lactate for mesenteric ischemia. Mesenteric ischemia, the symptoms will be far more than what signs you get. Usually, you will not be getting any signs. The only indication is lactate inappropriately elevated. That is the only indication for mesenteric ischemia. If you can detect mesenteric ischemia, suspect mesenteric ischemia early, and get a CECT done to confirm the diagnosis, you can save the patient. Otherwise, you might lose the patient. Pelvic exam in reproductive age females, if it is in the lower abdomen. Urinalysis for infection or renal stones. Consider pelvic ultrasound as imaging versus CT with contrast to identify appendicitis, diverticulitis, or pituitary colic. There are certain therapeutic goals which you need to follow. The most important in any patient presenting to emergency department is the physiologic stabilization. You follow the ABCDE approach. Airway takes precedence over anything else. Airway, then appropriately manage breathing, appropriately manage circulation, and then you proceed to diagnosis and evaluation of the patient. Mitigation of symptoms is very important. You need to comfort the patient, you need to control emesis, you need to give pain relief to the patient so that patient gains confidence on you. Expeditious diagnosis as early as possible is very important. Appropriate consultation as required should be therapeutic goals. Do not withhold analgesia to facilitate subsequent examination by a specialist like surgical specialist or a gastroenterologist. Analgesia should be titrated in combination of simple paracetamol, NSAIDs, and opioids in appropriate situations. If you are suspecting pain arising from a hollow viscus, better to avoid opioids because they can aggravate muscle spasms. So coming to the management plan, again an extract from the Rosen's emergency medicine. Abnormal vital signs are present. Yes. Administer fluids. Consider blood products if high suspicion of hemorrhage. No. Pain is present. Yes. Administer pain control. morphine, hydromorphone, or fentanyl, or you can use NSAIDs. There is no pain. Whether vomiting is present, if vomiting is present, administer antiemetics, ondansetron, prochlorperazine, promethazine, or droperidol. No vomiting. Clinical suspicion for infection. Yes, administer broad spectrum antibiotics early in the course, soon after collecting samples for blood culture. No signs of infection, signs of volume depletion, administer crystalline fluids, and no signs of volume depletion also. Diagnosis is unknown, symptoms resolved, consider discharge with follow-up. Symptoms are still persisting, consider admission for further evaluation. Diagnosis is unknown, no management as per the diagnosis which was made. So this is the management algorithm for abdominal pain. Other important medications to consider in a patient presenting with abdominal pain include antacids and antispasmodics. Gastric emptying using a nasogastric tube is a very controversial topic. Antiemetics to control vomiting are the best modality. Broad spectrum antibiotics, second generation cephalosporins and quinolones combined with metronidazole are the best choice of broad spectrum antibiotics. Thank you. A goal without a plan is just a wish. So before you have a goal, along with that you should have a perfect plan. Thank you. Thank you very much. Keep watching my videos. Don't forget to share and subscribe.